We're at the IAS here in Amsterdam. We're here with Martina Penazzato, who's with the World Health Organization. She conducts her business in Amsterdam, in Geneva, but you cover the whole world, so it's a pretty massive thing that you're going to be talking about with pediatrics today. So I guess first tell us a little bit more about what your work is, and then we'll go into what we've learned, what we've done here at the conference.
Sure, thank you very much. So our work is really to develop normative guidelines for countries to scale up diagnosis and treatment and be able to identify and treat children living with HIV.
That would be all the ages?
Yes, yeah, across age groups, including adolescents. So we're talking about 0 to 19, really. And we know that between 0 and 19, the needs change, and also the way HIV evolves and present change. We know that the needs in terms of treatment and diagnosis are different age groups, and we know that that's something that make pediatric and adolescent HIV testing and treatment a little bit more complex than what we do for adults, for example. And that has been a little bit of a barrier for scaling up testing and treatment in countries globally, particularly in low and middle income countries. What we are trying to do right now is really to make sure that that 1.8 million children living with HIV below the age of 15 are being identified in a timely manner, so as soon as possible, ideally within infancy, and if not, immediately after, and that they're started on treatment straight away. Because we know disease progression can happen very quickly in children. We know that if you don't provide any treatment, half of the children that are infected with HIV would die within their first 2 years of life. So we really need to act urgently, and that urgency is something that at times we forget.
So we have to identify it, especially when it's at the birth.
In the early days, in the early days. We have established algorithms to do that, meaning exact times where testing should be provided to children, to the mothers, and then to the infants. And we really try to optimize any opportunity that the mothers and children have to be in the facility and be able to be tested, to be able to identify them and start them on treatment. So obviously that doesn't always happen because health facilities are overwhelmed with a lot of tasks to do, particularly when it comes to immunization clinics or outpatient clinics or pediatric wards. And we know that testing is not conducted as much as it should. So one of our really main concerns is to make sure that we really promote HIV testing for children as much as possible, particularly in the early months of life, as I mentioned, in providing what we call infant diagnosis, or EID. There's been major progress over the past few years, particularly on the technology development side. That there's assays now that can deliver the results at the point of care in few hours. And this is something that has been scaled up by a number of partner organizations in a pilot phase initially, and now they're really showing the impact that these technologies can have on accelerating the initiation of treatment in children. And so we really hope that, as we move forward, these technologies can be further expanded and can be placed where it's most convenient for programs to really maximize the outcome.
Now, in mother-to-child transmission, you'd think it just wouldn't happen. So I'm just trying to dig through this a little bit through the weeds.
Sure.
People are actually, everyone knows, everyone in the medical field knows that the women who are going to be delivering a child should be tested, and in sufficient time they can get them on treatment, so that for their own good as well as for the child's good. Because, 2 out of 3 could become positive through the mother, through the childbirth. So it does make sense that we do this, but is it just because, for lack of resources, or the women who are potentially living with HIV are unaware of this issue?
So I think that, as usual, there's a number of different factors that influence this. I think one key point is that often women that get pregnant present to antenatal clinic quite late, and as a result, they are tested late and therefore started on treatment late.
So they could be too close to the birth time to get down to undetectable.
Yeah, that's one of the issues. The other issue is that while they start treatment, we know that starting treatment, particularly during pregnancy, when other things may get more difficult, may affect the way they adhere to the medications. Some of these medications have standard and well-known side effects that need to be considered.
So it's also the drugs that we're using are older, more difficult to manage drugs with side effects. Yeah,
I think there's that component. Of course, we are always trying to get better drugs that have less side effects. But I think even the ones that we consider to be good and effective, they can have some. And so at the beginning, in particular, can be challenging to adhere to that. And then we know that pregnant women are going through a really tough time postnatally in particular, right? They need to readjust to life. They have a new baby. Maybe they have a few at home as well, and being adherent to treatment can be really challenging. So that period of time is something that we've observed to be a period where we say that either they're lost to follow-up, so they don't come back to the facility to get their refill, or they simply are less adherent. And we know, we've seen over the past few years that while perinatal transmission, which is what the terminology we call to be, to really give a better idea of this particular transmission, it has shifted to be more in the to happen more in the postnatal period. And so this is a critical time where we need to keep in attention. The other component is that there are pregnant women that are negative and they're tested, they're not starting treatment because they don't need any. But then in the postnatal period may get infected. And the problem is that often that incident infection that happens in the postnatal period is not detected because women that are negative are not necessarily retested. And that's something that needs to be considered, particularly in settings where there is high incidence, and of course this is a bit more of an issue. So overall, I would say that perinatal transmission has been decreasing significantly, but it's not done. We still have 180,000 new infection estimated to happen in 2017. So we're talking about considerable number. So there's more that needs to be done to really prevent this to happen.
Who are the stakeholders in this? It's the pharmaceutical companies I know are doing their best to engage with the challenges that are here, but certainly WHO and others. Can you describe who those folks are?
Yeah, I think the work in pediatric HIV is extremely collaborative, particularly compared to other area work, and we really synergize and contribute in a different way. I think UN organizations like WHO and UNICEF certainly play a key role at the normative and on implementation level. We have implementing partners like the Elizabeth Glaser Foundation, ICAP, and many others that are in the field that have a strong presence on the ground. The Clinton Health Initiatives that helps us to introduce innovations on the medicine and diagnostic side. But we all work together, and of course nothing could happen without the support of key important donors that, like PEPFAR Global Fund, that have been really playing a major role in scaling up pediatric treatment. This morning we had a satellite talking about the lesson learned from the ACT initiative that PEPFAR and the Children Investment Fund Foundation supported in the past few years. And there's been a major amount of lesson learned coming out of that we are trying really to disseminate and use as we scale up treatment. So I think it's a very collaborative effort. You mentioned industry. I think that we are becoming better at interacting with industry partners. I think that in pediatric HIV is not something where industry has a lot of interest in, because the market is small, very fragmented, and quite difficult to handle.
But they used to do a lot in phase 4, which is after the drug is launched. Then they, let's see what we can do for pediatric AIDS. Well, now it seems like there's, like I was saying with VU, apparently their goal is they won't bring a drug to market which is not capable of having a formulation that will be appropriate. As we said, there's a lot of stuff that goes into planning a formulation that's going to be effective and useful. Yeah,
and there is really a there's been a major shift over the past 2 or 3 years in this type of work. funders like Unitate have really invested in some of the work that we do in drug optimization and in bringing all these partners together and defining key principles on how we can accelerate the development and introduction of new drugs for children. And industry is being, in some cases, very receptive to really do things differently and think about the development of new drugs and formulation, thinking already about the end user. But this doesn't happen overnight, and that's what I think we need to acknowledge. There's been progress. There's new drugs that are being introduced in treatment guidelines that are, and all of that is happening much quicker than it happened in the past. But there is margin to improvement, and I think that we can only do that if we all work together. I think it's clear that studies in children needs to be started much earlier than what has happened in the past. They need to be designed in a smart way so that we can get the results as quickly as possible, but also that we can get the results that really inform how the drug is going to be and used in countries. And we need to accelerate, all the steps that come from, on the full product life cycle, from research and development all the way to regulatory approval by stringent regulatory authorities, national regulatory authorities, as well as then procurement and supply at a country level. And I think that we are getting there. At this conference, we launched the Global Accelerator for Pediatric Formulation, which is a collaborative platform that has the really idea of establishing standards for how to accelerate research, development, and introduction of new drugs and formulation for children. And we know that that's not going to happen without the right funding that is developed in an innovative and sustainable way. And we really see all these partners that I've mentioned so far to be working very closely with industry because, no one can do that together. And it's really important that we increase communication, but also collaboration. So I think we are in a good place, but there's a lot of work to be done in the next future. And we hope that the Global Accelerator will provide the platform to really get that level of progress, not just for HIV, but also for other disease areas, because a lot of the challenges are very common to other infectious diseases. So we really hope that we will generate some positive change in other areas as well. I mean, ultimately, we want these children to live and to be healthy, irrespective of which disease.
Regardless of humanity, it's the cost to the government, to all resources that are strained at this point. So prevention is really important.
Yeah, absolutely. Prevention is critical. Yeah.
Thank you so much for being with us.
Welcome.
Thank you.
You're welcome.